It's fine.
Management, there is one comment that the link is not working. Can you just please check? I want to say that if someone attend, he can upload, but he didn't attend last time, his name, it will not be there, so he cannot get the certificate. If you are attending and you are not getting, then you can send us a message, so I can pass this message to, and they are following us. Please concentrate on the chat if there is any message and reply to them. Just another 1 minute, just to give a time, because all the times we are announcing that we are going to start 9:30. Usually we change our starting time, because now the time is changing and it's better to be 9:30, I think. And we want also the participant or our attendees, if there is any suggestion, that we are also planning to do sometimes on Saturday. So is it better to do on Saturday or Friday? We need also feedback about that. Maybe next time we will send also a survey about this one.
Brother Safwan.
Yes, my dear.
You will be covering safety and tolerability.
Yeah.
Okay. Because I have some slides more in details about, most of the side effects are mild to moderate. So,
yeah, I will pass through it through a study that shows.
Or you can just say that will be more elaborated by my colleague, so that.
Yeah. I will say that the details in this study will be discussed by my brother, Dr. Hayat, and But I will show the clinical approach, how to overcome it. That's my aim.
Yes.
The aim of this presentation is to go through a clinical points in use of the Zidra. It's not the details. The details is related to you. You know that all the time is for us. From 9:30 to 10:30 is for us. So you take your time. It's free for you. You can do whatever you need. You see, but Dr. Muhammad, he's supporting us. Novartis is supporting us.
Yes.
So we have a longer time duration.
Hayat and Safwan, 10-minute presentation and
yes,
5-minute discussions.
Yes, sir.
If there is any extra, we will stop. So don't listen to him, Hayat. He won't make you in trouble with me. Okay. I think we can go now and start. Okay. Assalamu alaikum wa rahmatullah. Good evening, good morning, good afternoon, dear colleagues and friends. Welcome to another activities of MIOM. And today we are actually talking about episode 5 of uveitis weekly knowledge. And we are having, as usual, 2 parts of the webinars. We will start with introduction of the speaker. So today, the episode 5 of non-infectious uveitis. Me, the moderators, and I have co-moderator Dr. Ahmed Salam. He's a professor of ophthalmology, vitreoretinal surgeon, uveitis specialist, staff Jones Eye Institute, University of Arkansas for Medical Science, USA. I hope that he can join us. He is also busy in the theater. The first part, it will be done by our colleagues, Dr. Safwan Al-Bayati and Dr. Hayat Khan. Dr. Safwan Al-Bayati, he is an consultant ophthalmologist and medical director of phaco-refractive surgeon, cataract, LASIK, vitreoretinal Vitreoretinal Surgery, New Vision Center, Dubai Healthcare City, Dubai. Dr. Hayat Khan, he is a consultant ophthalmologist, pediatric ophthalmologist, and strabismus, ocular genetic specialist, Mediclinic, Parkview Hospital, Dubai. Our speaker for today for uveitis episode 5, it will be Dr. Fahad Kohel. He's an ophthalmic surgeon, Royal Hampshire Hospital, with a private practice at Calmorment. Now he moved to Cleveland, Dubai, in UAE. So let's go to the topics. The first topic, it will be by Dr. Safwan Al-Bayati, when to use Xiidra for eye disease patients. And the second, it will be Dr. Hayat Khan, new strategies for dry eye. So please, Dr. Safwan, the mic with you. And now it is 9:35. You have 10 minutes, please.
I know, but I'm not able to share yet. Now I'm able. Good evening, everybody, and great thanks, Dr. Muhammad, for this nice introduction. And I need to thank you also to give us this opportunity through Novartis to present the clinical points and the use of Xiidra and when we need to use Xiidra. And that's the important issues in this speech for the dry eye. Now, I will go through and I will just highlight an important issues, which is the immune synapse that can happen in the inflammatory process that create the dry eye. And you can see that the T cell, when it's attached to the ICAM of the antigen presenting cells, through attachment of the ICAM to the LFA1 of the T cell, the synapse will start. And this synapse, when it starts, the cytokines will release. Now, that's simply, and I think that after me, Dr. Hayat, he will clarify all these points, but important issues in this point is that Xiidra act as a breaker for this synapse and prevent the formation of this synapse. So if you will go, that's why I'm presenting this synapse in this clarity. Let us go to the details of this immune synapse. So LFA, as I said, on T cell bind ICAM1 on antigen presenting cells, forming the immune synapse, which result in migration, proliferation, survival, and maturation of the T cell through increase in expression of ICAM1, T cell recruitment to ocular surface, T cell migration into ocular surface, T cell activation, release of pro-inflammatory cytokines, and T cell binding of antigen presenting cells. So I'm presenting it to show the importance of this immune synapse. So the breaking of this immune synapse will stop the inflammatory process. That's why we said that Xiidra is preventing and treating. It's not only preventing, it's a treating by breaking the synapse. Now, if we will go, Xiidra, as shown in the slide, Lifigrast or Xiidra will bind the LFA, preventing this receptor from binding ICAM on the antigen presenting cells. And by this, it will prevent the immune synapse. But it has the ability to break this bond. So it will stop and treat the inflammatory process. So I will go through, and this movie will show exactly what's going on.
Specifically designed to target a source of inflammation in dry eye disease, it is thought that Xiidra targets both inactive and active T cells, thereby helping to disrupt the continuing cycle of inflammation. Xiidra blocks LFA1 on inactive T cells from binding with overexpressed ICAM1 on the ocular surface and may prevent formation of a specialized cell junction between specific immune cells, which may inhibit T cell activation. Xiidra is thought to inhibit migration of activated T cells to the ocular surface and may reduce cytokine release. Xiidra is a first-in-class prescription therapy thought to target both active and inactive T cells in order to interrupt the chronic cycle of inflammation.
So from this point of view, we will see that the use of Xiidra, which approved by FDA, have the improvement from baseline, or it create the improvement from the baseline in sign of a dry eye disease. Near 8 out of 10 patients did not use artificial tear at day 90. But that's important, is that with the beginning of the treatment, yes, we need to use the artificial tear. And which kind of artificial tear, that's the important clinical points that we need to discuss it and clarify it and make a point on it in a way that it can facilitate the use of Xiidra, because the use of the artificial tear, the type of the artificial tear that we'll use with the Xiidra, will reduce its irritation and stinging sensation that might the patient feel it when using the Xiidra. Xiidra was well tolerated in the clinical trials, and in our clinical trials, it started to be much better tolerated with the use of the type of the artificial tear that compatible with the patient's situation. Novel and unique therapy with onset of action as early as 2 weeks, that it relieve the symptoms. Now, in CDAR's recommended treatment, if we will go to the 3 common types of the dry eye, aqueous tear deficiency, and blepharitis, meibomian gland dysfunctions, and goblet cell deficiency, 3 common use topical liftigrast was clearly effective in the treatment of 3 of them. And that's very important finding in this study, which is a global study, shows that it was showing the type of the treatment in a dry eye. I think that Dr. Hayat will clarify more around it, but it shows clearly that in this stage, which is this first line of the treatment, liftigrast was used in the 3 types of them. And definitely in the second line and third, it's surgical or oral use, so liftigrast will not helpful here in the second line of treatment. Now, for me personally, with my personal experience with more than 100 patients with use of Xiidra till now, the breakup time, which less than 10 seconds, is very crucial for me to start using Xiidra. Schirmer test less than 5 millimeter. It's one of the issues that it makes me go through and test and concentrate on the breakup time. Corneal staining. So what I'm saying here, it's all available with all our ophthalmologists in the OPD. It's a breakup time, and that's one of the important issues that I'm depend on Schirmer test and the corneal staining. Now, important point that I need to highlight it here. Which kind of the artificial tear that we need to use with the Xiidra to relieve the symptoms of the patient. Patient's coming to you in a condition that he don't know what's the Xiidra, what's the anti-inflammatory, what's the inflammation. He need to relieve his symptoms. Now, his symptoms coming from, in my experience, the breakup time less than 10. Once the breakup time started to be less than 10, the symptomatic irritation will start. And once the patient here in your clinic, the simplest test that we can start with before the questionnaire is the breakup time. If the breakup time less than 10, this patient will not get any benefit from any artificial tear that having only aqueous, only hyaluronic acid. This patient having defect in the meibomian function and in the goblet cell. So we need to relieve that. We need to improve the breakup time immediately. Then we can start the liftigrast. Otherwise, if we will start liftigrast on those patients directly without artificial tear, 100%, they will have the stinging sensation. That's why I'm saying that the artificial tear should contain lipid content component and aqueous component and the mucus component, which is equal to the tear. And that's what we needed from the artificial tear, that we should use it in these conditions, especially for those that they have less than 10-second breakup time. So the composition: hyaluronic acid, carbomere or methyl cellulose, and glycerol and mid-chain triglyceride, which equal to the all component of the tear, because those patients, most of them, they have defect in the goblet, because the goblet cells is the first cell that's affected by the inflammatory process, and it will lose more than 30 immediately within 1 to 2 weeks from the inflammation. So they will lose the ability to change the surface of the cornea from hydrophobic to hydrophilic. Carbomere or methyl cellulose can cover that and can enhance the wetting, so it relieves the symptoms. Here, if we will use the Zedra, 15 minutes, for example, after this component of the artificial tear, the patient will not feel any stinging or bad sensation from the use of the Zedra. Now, if we will go again, one of the important points that I'm using it is the eye protector application. That this is an example for the application that I'm using it, because most of the inflammation that's coming to our clinic, most of the dry eye coming from our clinic is from the excessive use of the computer or the devices, phone or computer. This application will give a message to the patient, to any person using the devices, that he's using the devices for example, in the setting, if he put it 20 minutes, and this 20 minutes, he will give him a message. This message remind him to blink, and that's an important process in enhancing the tearing and prevent or cut the inflammation. And that's why I'm using it frequently now, and I'm getting a lot of benefit. They are calling me back. Most of our symptoms is being relieved, because this is one of the important issues in creating the inflammation. And now I will go through these studies very quickly. We have 5 clinical trials, 2,400 patients. 4 of them, 12-week studies, evaluate efficacy and safety of Zedra versus vehicle. 1 year study evaluated the safety of Zedra versus vehicle. And in 2 of 4 studies, Zedra shows relief from dry eye as early as 2 weeks, the signs and the symptoms, and we can see. Now, in 3 of 4 studies, Zedra shows improvement in inferior corneal staining at 12 weeks. And 5 clinical study with over 2,400, as I said. Most common adverse event that Dr. Hayat will highlight it more, it's the stinging sensation and the test of the material in their mouth. But the stinging is that irritating the patient and let them stop. That's why they were calling me that we in the beginning, when we start using this medicine, before enhancing the approach of the use by the use of the artificial tear, that we have a stinging sensation. That's why we stop the medication. So I'm telling them that you should use the artificial tear at least 15 minutes before the use of Zedra and 15 minutes after the use of Zedra. Now this is the first patient, 45 years male, with the breakup time less equal almost 5 seconds, Schirmer test 5, and MMP 9 positive. Patient stopped all his medication for 1 week and came to me. And that's the first video, and shows that the breakup time was less than 5 seconds. Clearly here in the lower, unfortunately that the light is not, and it need to be clear. Now I will repeat, because now I enhance the light. This is the second movie, I think. Just I need to go back to the first. Sorry for that. Now, if you can see,
we are already 14 minutes now.
Now 14 minutes, because you took 5 minutes from my side. So just give me only
14,
1 or 2 minutes
from your start. Okay, please.
Please, if you don't mind. See, you can see now the lower here, the breakup time started. And if we will go to the second, and then here 2 weeks after the treatment, and we can see that the time will over more than 10 seconds, and there is no breakup time. Sorry, the tear is not break. I will go to the third and directly see here. It's in this case, it was immediately. There is no time for that. And I will go to the second. This is after the treatment, 2 weeks, and show much more improvement. Definitely still blinking from the breakup. It shows that breakup started. Now this is the last. See, directly, immediately that the breakup is clear. And 2 weeks, sorry, 2 weeks later, it's very clear. Now, Dr. Muhammad, I'm finishing that conclusion. And in conclusion, dry eye is a disease in which inflammation play a key role in its mechanism. It's important to treat the inflammation in dry eye disease and stop the vicious circle that Dr. Hayat will show it. Steroid is a very potent anti-inflammatory, but we cannot use it for a long time. Zidra drops is a safe and effective anti-inflammatory to treat dry eye disease. Great thanks for all, and I'm very sorry for delay.
Thank you very much, Dr. Safwan. So we can move directly to Dr. Hayat. Then if we have a time, we can do a discussions, please. Dr. Hayat.
Thank you very much. Thank you, Dr. Safwan, for an excellent presentation. Thank you, Novartis, for giving me the chance to take this talk. And in continuation to whatever my colleague, Dr. Safwan, said, definitely inflammation is a key player in dry eye disease. It causes evaporative, mixed, or even aqueous deficiency in the long run. And we have to break this cycle. And I will not go into other details, which my colleague has already covered. I'll come straight to the safety and the tolerability. And that's a very important thing that we have to look into if we are prescribing Zidra to our patients. Now, just to see what are the things are, of course, there is subjective and objective testing. Subjective, when we say, we ask the patient, we have a questionnaire about dry eye score. The question is within the 5 to 10 minutes of your consultation, how best you can utilize the time to arrive to the best of the diagnosis. So you have to, while taking the history, be very fluent in asking the questions and getting an assessment and scaling the patient based on their experience. And then, of course, we have to see fluorescein. I usually do fluorescein staining. My colleague, he's more likely to do, of course, tear breakup. I also do, but of course, Schirmer's test is what he relies on. So now coming on to most importantly, most of the patients, they would come back to us and they will say, doctor, there is a lot of irritation in the eye. And a lot of people, if you do not do a good counseling, they will not be happy. And that's where I want to most importantly reiterate that the key thing in starting Zidra is 5 minutes of counseling with the patient in which you explain that, listen, you'll put the drops, it will burn, don't worry about it. That's how it is. Most of the patient complaints, maybe you will not complain, but I always tell my patients, and I'm telling you that it may give you some stinging while you put in, but this is a good medicine. And the second thing is, of course, you will feel something in your throat, and that is also part of the treatment. Just wait for a while, be patient, and you will get good results. That's a very important statement. I usually spend about 5 minutes in counseling, explaining the patient that this is so important, because otherwise patients will not be happy. So most of these adverse events, whether it is feeling of dry eye, reduced visual acuity, or reaction or burning sensation at the site of installation, or a distaste, a taste alteration, all of them are there, but they are mild to moderate as per this study that you see here. And also important is within the same study, if you see, there were only 2% patients who discontinued Xiidra based on taste sensation, burning, or pain. Now, why this is important? These are those patients where doctors have been very diligent in explaining the patient what they can expect with the treatment. What would be their long-term goals? What would be the immediate problem that they may face with this drop? And that's very important. Now, of course, the Sonata study, in which they looked in that after 14 days, these patients who started on Xiidra, they became less dependent on using artificial tear. So in my presentation, I will have one case, very specific case. Of course, we have a lot of dry eye patients that we have been prescribing Xiidra, but specifically, I will take up one case, a post-operative patient who landed up with a severe dry eye, who had dry eye and then landed up further dry eye, which I'm going to discuss in the end. So here, of course, the patient felt better using this. And now I'm coming to this real world effectiveness study, which was done in the US and the Canada, a retrospective, non-comparative longitudinal cohort study in which different healthcare providers were put into, and a pre-index period and a post-index period was chosen in this study design. And then after the confirmation of dry eye disease, a pre-index period of 6 months was chosen before they started the lifitegrast. And then post-index, they had almost 6 months minimum of usage of this medicine. And 600 patients from 517 different practitioners were taken to to decrease the bias. And then they were looked in between 6 to 12 months after starting the treatment, in which different types of dry eye disease, where majority were evaporative types. There were about 27% mixed type, and the rest were aqueous deficient and others. And when they did this study, what they found was that the population in which more than 90% have a follow-up about 6 months post-index period, and 45% have follow-up at least 12 months. And in the results, they found a significant improvement in several signs of dry eye disease. So breakup time and corneal staining score. If you notice here, between the blue, that is 12 months, dark blue, the light blue is 6 months, and then the pre-index period, if you see, there is a clear correlation and improvement of both the tear film breakup time as well as the corneal staining. And then when they looked into the eye dryness, burning, and the subjective feeling, the patients were much more comfortable over the period of time, over 6 months and 12 months. So to make it very conclusive, because I don't want to go over time, these patients were looked in, and a lot of these patients were earlier using different other modalities like cyclosporin, corticosteroids, lid hygiene techniques. And as earlier taken up by Dr. Safwan, meibomian gland dysfunction disease is again a very big problem, which goes hand in hand with dry eye. And these patients were all put in together to come up with a final conclusion that lifitegrast significantly improved several signs and symptoms in the real world observation. And most of the patients, majority of the patients, were over the 12 months of post-index period, they felt much improvement. So lifitegrast is the first and the only lymphocyte function associated antigen antagonist, and it is an FDA-approved treatment of sign and symptom of dry eye disease. Now I'm coming to this patient. This patient came with a third nerve palsy post road traffic accident, and she already had a dry eye because of her lid disease problem, and of course she had third nerve palsy. We did the surgery, and after surgery she landed up with a bigger problem, her dry eye disease. So this is clear inflammation, and this was a clear case in which I thought, let me see, because this patient was earlier using other modalities, and then we moved her to Xiidra. Excuse me. And what we found that after we started the medicines, over 3 weeks, we found an amazing improvement in the fluorescein staining. And of course, I am not allowed to give the video of this lady, because she wanted me to share her real life feeling of how she felt when she used it. So very importantly, this patient complained to me when I started the drops, in spite of my telling her and counseling her, she said, "Doctor, this burns. This is, I put pepper in my eyes." And we had the initial hurdles of burning of eyes, in which I did a lot of counseling. Sometimes you should have your nurses who are ready to give a call back to these patients to talk about how they are feeling, to make the patient more comfortable. And as the time continued, over a month or two, her experience that she became less and less dependent on artificial as compared to any other modalities she used earlier, and she was very happy. So in total, what I may say that there are many alternatives, and Xiidra is an amazing alternative, especially where we are expecting one of the important issue of inflammation and we want to treat it. Thank you so much. And here we go.
Thank you very much, Dr. Hayat, for this excellent presentation on time. Very nice. So, Dr. Safwan and Dr. Hayat, we can now just have a few questions. There is one question from one of our colleagues. Dose per day. What is the dose per day for the Xiidra?
Well, Dr. Muhammad, it's recommended to use it 3 times when we have a severe dry eye. And in cases that mild, I'm using it twice now, and I just need to comment on one issues that Dr. Hayat mentioned.
Just Dr. Safwan, if you allow me, let me finish this question. There is many questions here. Let us finish, then you can have a time to comment. How long time should patient use, Dr. Hayat?
This is between 3 to 6 months is what would give you them very good results. Yeah. But it can be continued as long as a year without any problem.
Is there any contraindication to use?
As long as the patient does not have a hypersensitivity to the drug, there are no contraindication, except for we don't know what are the effects on pregnancy and lactation.
Yeah. Now, pregnancy and lactation. There's no study on the pregnancy and lactation till now, but we are not. We don't know. That's why we are not using it.
Okay.
But long run.
Sorry. Can patient with corneal erosion with severe autoimmune disease like scleritis use it? Can we use it, you mean, on autoimmune scleritis?
It's off-title, means that we don't have study off-label. Sorry, we don't have study for that, but I'm using it personally. I'm using it.
Me too. I'm using in even graft versus host disease. Anywhere where I'm feeling there is inflammation, I use it.
Yes, I'm using it in one case of Stevens-Johnson syndrome, and it gives a very good relief to the patient, and especially that those patients suffering from a severe and they are resistant even to the steroid. So that I'm using it 3 times for them, and it gives a very good result. But there is no study. We don't have any study behind it.
Okay, it is a personal comment. Okay, so is there is any other question? Does in case of Sika syndrome, dose for 6 months, is it effective or we need more?
Well, we need to use it as much as we can to relieve the symptoms of the patient. Means that why they are stopping on 6 months if the patient is still symptomatic and there is no any side effect from the drug. So we can continue up to the time that patient will be relieved or free from the symptoms and the sign.
Okay, there is another question maybe I will ask, but let me have your comment very fast, Dr. Safwan.
The important comment here is that when the patient starts, 100% that especially for the case that Dr. Hayat presented with this lower corneal staining, 100% the patient will have stinging sensation. That's why I return back to my presentation. Here in those patients, I'm using the artificial tear that cover those staining with the carbomir, and that's important 15 minutes before the use of the liftigrast or Xiidra. That will give them a very good relief. So it will reduce the sensation because carbomir can stick on that site for 3 hours or more, and it gives a very good relief because the bad sensation, the stinging, the burning, the chills-like sensation in the eye, it comes from that site defected in the cornea where the Xiidra will touch it. and because they have mist in goblets, and their meibomian gland defective. So carbamide can work in a good way with the Zidra 15 minutes before and 15 minutes after.
That's a very good comment, Dr. Safwan.
Okay.
I
Is
just
there
want
any
to
comments
add
from
one
your side,
last,
Doctor? Yeah.
one last comment I would like to make. Even patients before, if we get a chance, whenever we are planning cataract surgeries, if I get a chance to give them, and if there is a window of 1 or 2 months, there also I feel Xiidra is very good because it improves all my calculations, all my the surgical,
Exactly.
Dr. Safwan, you want to add?
Especially when those that they have corneal map changes. When they are coming to us, I fully agree with you. With the corneal map changes, I'm sure that they will have changes in our calculation. Yes, I will start with them when everything will be relieved and their breakup time will be returned back to normal with the simple use of artificial tear. Then I will stop it, and then I will start my cataract surgery or any procedure.
Okay.
Definitely.
Can you move now to, if you allow me, there is 2 more questions, but I need breathe, please, very fast, because already we are over the time. So any study about its use in GVHD? Actually, I don't know what he mean. GHD.
This is what I was saying. And not to my knowledge, there is any study, but I can tell you, I have this is where I used, and I have a very good, because this patient came specifically with filamentary keratitis.
Yes.
Which is again a sign of so graft versus host disease patients, they do very well with this. But of course, you have to augment it with a lot of lubricating drops.
Yes.
Okay. What is the difference? I think this one is any one of you, but what is the difference between these drugs and Systane eye drops? I think Systane is something completely
What do you
different.
mean by Systane? Systane is only an artificial tear.
Okay, there is a question like this.
So
that one is a normal. The other one is
one is just for the treatment of dry eye, and this one is this will just for the time being, just like something take off fever. That's it. But this one, Xiidra, is what actually decreases the dryness. There's a difference.
Now, the issue is important here. We need to differentiate when we are talking about artificial tear. What's the content of the artificial tear? When you are saying Systane is the part of the issue, part of the artificial tear that have only hyaluronic acid. And when we have hyaluronic acid alone, it's for the patient that have corneal staining, it's not enough to use that drops. What I mean is that we have a lot of artificial tear. So we need to select according to the patient condition, not according to the company. So for those having corneal staining,
we are already over the time, please, if you allow me. Sorry. We are over the time. Maybe at the end, the presentation of Dr. Fahad, it will be very short. So we can have the presentation about non-infectious uveitis by Dr. Fahad Kuhail. It will be pre-recorded because unfortunately he's unable to join us. So we'll listen to that. Then we can have a few questions in my mind about Xiidra at the end. Okay, let's go. Can you share, please?
Good evening. My name is Fahad Kuhail. I'm a newly appointed consultant ophthalmologist, actually at Moorfields Eye Hospital in Dubai. Previously worked as a consultant ophthalmologist at the Royal Hampshire Hospital in Sheffield in the United Kingdom. I'd like to thank Mohammed Al-Amri for asking me to present a short talk on non-infectious retinal vasculitis. I apologize that I'm not there with you today, but unfortunately today's webinar clashes with a pre-booked appointment. I do apologize for the inconvenience. So the first case I want to present is of a 24-year-old gentleman who presents urgently with acute hypopian uveitis affecting the right eye. His vision is reduced to 3/60 with no ocular inflammation affecting the left eye. From the history, I could identify that he had a previous rash affecting both lower legs, which we call erythema nodosum, and he had a history of recurrent oral and genital ulcers. Clinically, on examination, he had this nodular a maculopapular rash on both lower shins. He had a macular infarct with a dense hypopian uveitis with macular edema on OCT. Fluorescein angiography again confirmed a laterality of the retinal vascular inflammation. So although the left eye clinically didn't appear to be involved, there was definite evidence of angiographic vasculitis in the left eye, with marked vasculitis in the right eye, with macular ischemia on fluorescein angiography. This gentleman had Behçet's disease and was admitted urgently for pulsed intravenous corticosteroid, followed by oral steroid. He was also referred to a rheumatologist to start him on anti-TNF, and 4 years later, he's been managed very well on low-dose steroid, azathioprine, and adalimumab, with excellent visual outcomes, 6/5 in both eyes. I have another case, 25-year-old gentleman presented with a 2-week history of reduced vision in the right eye. A branch retinal vein occlusion was identified in eye casualty, and he was referred to our vein occlusion clinic at the Royal Hallamshire Hospital. His presenting visual acuity was 3/60 in the right eye, 6/9 in the left eye. Again, on systemic inquiry, we'd identified some recent weight loss with no respiratory problems or skin rash, but he had a history of inguinal lymph nodes. So this was his color fundus photograph, which shows an infratemporal branch retinal vein occlusion. But if I draw your attention to the infratemporal vein, and as you can see, there's a vascular sheathing or a periphlebitis. So already we're thinking this is a posterior uveitis leading to a secondary retinal vascular occlusion. He, of course, had macular edema on OCT. And the fluorescein angiogram again confirms vascular leakage of the infratemporal branch of the retinal vein with marked staining. This was his left eye, confirming no posterior involvement of the left eye. So this was unilateral retinal periphlebitis. Again, because it was a unilateral side and because of the history, we suspected sarcoidosis. We performed a chest X-ray which confirmed bihilar lymphadenopathy. Because it was unilateral with no systemic problems, we had a discussion with the patient and we decided to treat it locally. So he underwent an intravitreal Ozurdex injection to the right eye, followed by 3 intravitreal anti-VEGF Lucentis injections. So we treated both the inflammatory and the anti-VEGF component to his disease. With 3 years later, his vision maintained at 6/9 in the right eye. He at some point also developed some inferior retinal neovascularization, so we performed some panretinal laser photocoagulation to treat his disease. This is another case. So this is a patient who presents with a long-standing history of floaters, maybe even flashing lights and night vision problems. You look into the back of the eye, there is marked vitritis with multiple chorioretinal atrophic spots affecting the peripheral retina. It is bilateral in nature. So you've got bilateral vitritis, widespread bilateral chorioretinal spots, and you may also have an anterior uveitis in addition. So we're looking at bilateral panuveitis where the front, vitreous, and the back of the eye is all affected. This is his OCT, which shows bilateral macular edema with increased central macular thickness. And this is the fluorescein angiogram, which shows bilateral disc leakage with some late shots showing some peripheral retinal vascular leakage. However, the ICG is the clincher here, which shows widespread choroidal hypofluorescent lesions within the late phase. We suspected bilateral. Sorry, guys, I'm just going to go back. It won't let me go back. I do apologize. So we suspected bilateral. This was a bilateral panuveitis. It's very important that you consider infectious causes like TB. Syphilis can masquerade like this, but also important to consider non-infectious causes like sarcoidosis, VKH, multifocal choroiditis, or birdshot chorioretinopathy. Because of my familiarity and experience, I felt that this was more in keeping with birdshot chorioretinopathy. So we performed HLA-29 typing, which confirmed the diagnosis. But before starting this patient on treatment, we did exclude infection. So we did BDRL to look for syphilis, and we also did a quantiferon to exclude TB. Because his vision was 6'9", 6'6", I did not start him on steroids straight away till I had an opportunity to confirm the lack of infection. Then I did a chest X-ray to make sure there's no chest infection. Then I started him on high-dose steroids. And then within a few weeks, when there was clinical improvement, I started him on a second-line immunosuppression, like mycophenolate. But then 8 weeks later, he still was not satisfied with the improvement in the vitritis. So we ended up having to give him anti-TNF, adalimumab, and only at that point was the patient satisfied. But unlike the first case where there was Behçet's, where there was a macular infarct, where urgent treatment was of the essence to ensure that the patient did not suffer any permanent vision loss, in this case, because it was gradual onset, the vision was still good, I actually paused, took time to ensure that there was no infection, excluded those infectious causes before starting the patient on steroid as well as systemic immunosuppression. This was his fundus photograph after being on the adalimumab, and you can see there's a marked resolution of the chorioretinitis and vitritis. I'd like to thank you for your kind attention, and again, my apologies for not being there in person, but hopefully my colleague Ahmed Salam and Mohammed Al-Amri, who are the panelists, will be able to answer any questions and any queries on my behalf. Assalamu alaikum wa rahmatullahi wa barakatuh, and I'm very excited to be joining the United Arab Emirates. I look forward to meeting you all in future meetings. Wassalamu alaikum.
Okay, we'd like to thank Dr. Fahad for his presentation. Unfortunately, it happens that he couldn't cover all the topics, but we promise all our colleagues that we will have another time to cover non-infectious uveitis. He was able to show 2 cases and to cover some of the non-infectious uveitis under cases, so it will be for discussions. Also, unfortunately, Dr. Ahmed Salam is not with us today. If there is any questions, and we are having Dr. Safwan, Dr. Hayat, they can join us. I know all ophthalmologists, they can give their opinion, and we will see. So if there is any question from colleagues, yes, there is some comments from Dr. Ashraf Awaja. He was saying the diagnosis of the first case is Behçet's, as Dr. Fahad also comment about that. So if there is no questions about this one, so we can have we can go back to Zedra, and I think we are having other questions came.
I have a question.
Yeah, you have a new comment, please. Yeah,
Brother Safwan.
Yes.
So no, before that, Brother Fahad, thank you so much for an excellent presentation. I just have a quick question regarding there are sometimes unilateral anterior uveitis cases coming in, and when we look in, we don't find anything. We keep on testing, and they turn out to be tuberculosis quantiferon positive. Then we refer this case for further opinions, and then we find that they. My question is that let's say, of course, some of them turn HLA-B27 positive and mild history of some joint pain. So should we give these patients ATT, which I think a lot of these patients are getting, or what is the best way to move with these patients? Unilateral uveitis or chronic uveitis patient unilateral?
Anterior uveitis.
Yes, anteriors. Non-granulomatous anterior uveitis.
Most of the time, I think uveitis, anterior uveitis is a simple time, and you cannot find a cause behind. You are doing all the tests and you didn't find any response. Even sometimes it's recommended not to do all the tests, because if it's unilateral, just you will instead of doing all the tests, you will not find anything. So just you will treat it simply by topical steroid, and you will see there will be a very good response about that.
Well, the thing is,
this is what I'm not specialized in.
We have patients which are very vigorous, and even if you give 2 hourly, 1 hourly Pred 40, the inflammation is not. So you have to start methotrexate. You have to discuss this with your rheumatologist.
So maybe this one, I think it's better to be referred to a specialized one person for uveitis. He will do a special test, because sometimes we are missing. Uveitis is not, sometimes is very easy, but most of the time is very difficult. And need also to have a good experience and seeing a lot of patients, so you can select a proper treatment. And sometimes you will miss something because you are not. It could be a systemic, also associated with systemic, even though it's very difficult to find a unilateral unilateral uveitis, anterior uveitis, and associated with systemic disease. Usually it will be bilateral. I don't know, Dr. Safani, any comment about this?
Yeah, I do agree with you, but Dr. Hayat is talking about a chronic unilateral, a repeated one. That's the issue. That I do agree with you totally, that I will not keep investigating them, and I am sending them to the specialist uveitis. Thanks God that now we have in our country specialist uveitis. And we are sending them these cases, and I think that those they can handling them.
Thank you.
Okay, so we have a few questions for the ZEDRA. We will go back because I think we don't have any further questions regarding the uveitis. Let me just do last check. Okay. There is only one thing that I want just to comment, actually. Most of the time in any medications, when we are dealing with dry eye, and most of the time either ZEDRA, or if you are talking about cyclosporine, when you are giving them as an anti-inflammatory, and the patient will feel a pricking sensation, stinging pain. I think the most important is to use a drop, just one drop, before using any artificial tears, before using these drugs. So you will feel that he will not feel this pain or just immediately, just because the ZEDRA, it will come on the top of any artificial tears. I know Dr. Safani is talking about someone that can cover all the 3 layers, sorry, and use it after 15 minutes. But this is a very simple way. For the test, most of the time we are just asking our patient just put her hands on the punctum for a while. Then he will not feel all this bad test if there is a feel. If he feel, but it's not available with anyone. Not all the patients they are having the same comment. But if that happens, so from the start we are asking them to use this one. To have a good result, we are usually using a steroid for 2 weeks. Then we get a good result after 2 weeks with the medications. I don't know if we can take out the all dry drops, labricating eye drops from ZEDRA or not. Yes, Dr.
But the issues is that here we are doing a study now for those patients that they are coming with a breakup time less than 10. How we can improve that breakup time immediately by artificial tear. And what we did is that we differentiate the artificial tear to 3 categories. First one, those that they have hyaluronic acid, means that only supplements for the aqueous. and those that they have the lipid and carbamide with the hyaluronic acid, or lipid and methylcellulose with the hyaluronic acid. And we found that those that they have the carbamide, they can increase the breakup time from 3 seconds up to 8 or 9. So, and immediately the patient will be improved. The symptoms will be improved. So what we are saying, instead of using the steroid, try it. When you have a breakup time less than 10, just use the drops that can enhance that breakup time. And those that they have only lipid, they can enhance it, but it's only for few seconds, 2 or 3 seconds. But those that they have the carbamide, they can, or the methylcellulose, those two groups, and they can enhance this breakup time up to 10. So the immediate action to those that they have symptomatic, severe symptomatic, is to relieve these symptoms in a way that prepare their eyes to use an anti-inflammatory that it will treat the cause for, or that break up the inflammatory vicious circle to treat them. Otherwise, if we will not use a proper artificial tear, if we will keep them, for example, in this situation and use a drop of Zedra on that side, 100% they will have a severe stinging because it will be irritated, because the nerve ending through those areas that creating or showing the corneal staining is very sensitive. So simply what we are doing is that to solve or to answer a question, to answer a simple, to answer a question.
Dr. Safwan, I think the idea is very clear. In your idea, I think it's clear. Is there any other comments from Dr. Hayat, or before we conclude?
That's it. That's pretty much very clear.
I think this is, we know it's now we are getting an experience as we are start using one by one, so we will have build up more experience. But it is another facilities that it's encourage us or give us an opportunity to treat the dry eye. I mean, another weapon that we can use it, so we can improve our treatment and management of dry eye. And dry eye is really a big problem. It's more than 80% of our patients, they are having dry eye, especially in our area due to weather and due to using of AC nowadays. But there is a question, safety in using a pediatric. What is the age of that we can start using Zedra in pediatric? What is the age?
I sent that message. First of all, dry eye disease is not typically in children. It only happens in children when they have any other disease which is causing inflammation. Children don't get dry eye disease. They may have allergic conjunctivitis, severe type, which may indirectly cause dryness, and then there is an inflammatory mediators there involved. Those cases.
But nowadays, Dr. Hayat, I think, I don't know if you are agreeing with me or not, now using of the devices, it's increased between the children, and even 4 years they are having this one, and they are using a lot of times. So some of them they are studying, and from the home 6 hours, 7 hours, just continue looking to the laptops.
I agree to that part. I agree.
That's why they
I am now getting surprised when I see a lot of young kids having the dry eye.
So an important issue.
We are talking dry eye is for all, but nowadays,
this is like you will see that there. And also, I don't know, Dr. Safwan may agree to me. Sometimes blinking habits. I have some videos I can share. Some people, I don't know, it is because of screen time or what. People, their lid doesn't cover their whole cornea. The lid goes halfway and goes up, goes halfway and goes up, and you can see the line. And you get exposure keratopathy. I don't know how often we used to see. And now it is so common.
Exactly. Now, I just need to comment that let us ask the question in different way. Can we use the Zedra in those children that they have allergic conjunctivitis? Now, the answer is clearly yes. From which age? Now, for me, I start from 6 years, and I have a very good result, especially for those that they are very sensitive. They are myopic from 6, and we cannot use a steroid, just scare from the steroid-induced glaucoma. And those I start use as Zidra twice a day, and it's very safe for them, and they are using it, and it's not creating anything. Now, return back to your comments related to the blinking.
Now, Dr. Safwan, allow me just one second before your comment. I want management, please, to upload the link for today, say a certificate of attendance, and please keep the link and the webinar continue 10 minutes after we close, because so many people they are telling that they are just immediately you are closing and they cannot get their certificate. Sorry, Dr. Safwan, if you can comment.
So the second part is the blinking. So what I'm saying is that I'm asking those patients to put a portable camera in front, because they don't believe that they are not blinking. So a small portable camera that connected to their phone and record what they are doing in front of the computer or in front of their phone. And they shocked because they are not blinking at all. And then after that, they are calling, for example, someone that we did any procedure or even treat them. They are calling me, sir, but I'm not seeing well. I just finished the work and I start seeing distance blurred, because these corneas start to be, the superficial epithelial cells start to be gray line, the gray color, because he didn't blink. So that's why I show the eye protector app, which is very important. It gives them, I'm putting a special sound for this message, and this message coming to them and remind them that they need to blink, and they need to blink 20 seconds every 20 minutes, or they can adjust it or setting it to 40 by 20. So every 40 minutes, 20 seconds. It's very important. With the time, their blink will be fine, full, because the irritation of the lower corneal staining prevent that lid coming down, and that's why it aggravates the issue.
Thank you, Dr. Safwan. Just I want to remind my dear colleagues here and attendees that we, by the end of July, we will select those they are going to be free registration in MIOM. And also I want also to announce that now our website, www.miomacademy.com, you can go and search for that. You can find all the information about all the activities of MIOM and about the activities of conference registration, companies that they are participating, all the information you will need. And if someone who wants to have any more information, just also can send an email to us. We are ready. So the early bird registration, it will be finished by the end, I think, of July. So please, if someone wants to register and to have the opportunity to have an early bird, which is less than the on-site registration. Also, we are going to start our what we call cornea and refractive episodes. It will start from 1st of August. So, and we will select from at the end of August, we'll select those they are will be eligible to be free registration, and we'll select also those they are attending all the episodes. For each episode, we will select 3. They will have also 3 accommodations, accommodation free in the conference. So I would like to thanks all of you for attending this meeting. It was a great to have also Dr. Safwan after a long period of time, you know, because we are only doing uveitis and medical retina. But sure, after a while, you know, we'll start fighting, inshallah, from 1st of August because of refractive.
So I will
fighting medically fighting, you know, scientifically. I like that all the time. Thank you, Dr. Hayat, for being with us. I would like also to thank Novartis for sponsoring this webinar. Thanks for Dr. Fahad. And I apologize also because this one, it doesn't cover the things that I want in non-infectious uveitis, but we will highlight it more, inshallah, in the next webinar. It will be on the next webinar. It will be medical retina. It will be on 25. It will be Sunday, because we are having another activity here in UAE on 24 and 25. So 26, we will have this on Sunday. Then we will have Wednesday, which will be 29 and episode 6 of uveitis. So please stay alert with us, and thank you very much, and we hope to see you soon. Management, please keep the webinar open for at least 10 minutes after we close. Anything before we close, Dr. Safan or Dr. Hayat? Yes.
Thank you very much.
Great,
Thank you for inviting.
great,
thank you very much. It was a very nice
Dr.
and
Safwan, it was a pleasure.
good. Thanks a lot. Thank you very much. See you, inshallah. Assalamu alaikum. Bye-bye.